Hi everyone, I'm Dr. Arash Shahraman, an endodontist, oral epidemiologist, and professor at Kerman University of Medical Sciences. With over 90 published research articles, I'm passionate about translating cutting-edge dental science into clinical practice. Welcome back to the channel. To our returning viewers, your engagement truly inspired this journey. New viewers, you are joining us at just the right moment. In each video, we'll analyze multiple landmark studies and their practical implications for your daily practice. This month, we are diving into the most impactful endodontic research from February 2025. I've handpicked these studies, covering breakthrough techniques and essential clinical pearls to help you in your practice, whether you are a specialist, general dentist, or dental student. Grab your favorite drink and join me as we explore the latest science transforming our field. First up, let's tackle a hot debate in endodontics. Does progressively enlarging the root canal during canal preparation actually increase the risk of microcracks? As an endodontist, I perform root canal therapy almost every day. When I use nitty rotary files with a large taper like an 8% taper in narrow canals such as the MB2 of a maxillary molar, I wonder are we risking microcrack in dentinal walls? So today, let's dive into the evidence. Is this a real concern, or are modern techniques minimizing the risk? Now, let's look at this important study from Brazil by Dr. Carolina Oliveira de Lima and colleagues, published in the International Endodontic Journal. The title is Microcomputed Tomographic Evaluation of Dentinal Microcracks in Response to Progressive Taper Enlargement in Root Canals of Maxillary Molars. Here is what they did. They took 20 maxillary molars, 10 with MB2 canals and 10 without, and scanned them with micro-CT. Then they prepared the mesiobuccal and distobuccal canals step by step using nickel titanium file, up to size 8% taper. After each step, they did another micro-CT scan. Here is what they found, and this is fascinating. 2.8% of slices showed dentinal microcracks. But here is the key point. Every single microcrack they saw after instrumentation was already there in the pre-treatment scans. This means something really important for our practice. Progressive enlargement with different tapers, even up to 8%, didn't cause any new microcracks. And it didn't matter whether the tooth had an MB2 canal or not. So when we see microcracks after treatment, they were most likely already there before we started. This is great evidence that our modern techniques are safe. Let's examine a clinically significant anatomical variation, the palatogingival groove. This developmental anatomy most frequently observed on the palatal surface of maxillary lateral incisors represent a notable risk factor for combined endodontic periodontal lesions due to its plaque retentive morphology. Now, pop quiz. How common do you think these grooves are? 1% of population? Maybe 3%? Could it be 10% or even 20%? Dilan Pelin Yildirim and colleagues from Turkey published a paper in BMC Oral Health investigating the prevalence of palatogingival groove. Their study revealed palatogingival grooves were present in 2.8% of maxillary incisors and 9.4% of population, most commonly found in maxillary lateral incisors. Type 2 and 3 of palatogingival groove that are more severe form of it, frequently associated with periodontal bone loss and preapical lesions. Notably, most palatogingival groove affected teeth with periodontal bone loss and also showed preapical involvement. And now a clinical implication. When you encounter a maxillary incisor with narrow periodontal probing depths, preapical pathology, but no caries, cracks, or restorations, think about palatogingival groove. And now the answer of the quiz. Almost 10% of population is correct. And honestly, before reading this article, I thought the frequency must be 1 or 2% of population. Let me discuss another interesting article. These photographs and radiographs are from one of my patients. The left maxillary canine is symptomatic and requires endodontic resurgery. As you can see, there is a dental implant adjacent to the tooth. As demonstrated in these 6 months follow-up photograph and radiograph, fortunately, both treatment approaches achieved complete clinical success in this case. This raises an important clinical question. What has better success rates, endodontic microsurgery or a single implant? Which treatment option would you consider more predictable? Min Jang Ko and colleagues from Korea conducted a systematic review and meta-analysis published in Restorative Dentistry and Endodontics Journal. Their study, titled Comparative Success Rate of Endodontic Microsurgery versus Single Implants, a systematic review and meta-analysis, using comprehensive explicit criteria, provides valuable insights into the clinical debate. Let's break down this fascinating finding from this meta-analysis. The researchers analyzed 22 studies on endodontic microsurgery and 6 studies on single implants, and here is what they discovered. The numbers speak for themselves. Endomicrosurgery had an 89% success rate. Single implants showed 78% success rate. But here is the really interesting part. When they compared the studies with similar follow-up periods, the success rate were actually quite similar. This gives us important clinical insight. When we have a tooth that's a good candidate for either treatment, microsurgery should be our first consideration. Why? Because preserving natural teeth is always preferable when we can achieve comparable success rates. Alright, let's talk about another fascinating article. When we perform root canal therapy of a maxillary molar with irreversible pulpitis, our patients sometimes have pain during entering palatal canals. Do you have similar experiences? Recent study by Duygu Kolay and colleagues again from Turkey in BMC Oral Health examined anesthesia for painful upper molars. They tested 2 approaches, buccal infiltration alone or buccal infiltration and palatal infiltration, and here is their key finding. There was no difference between articaine 4% and lidocaine 2%, but adding palatal infiltration significantly reduced pain during entering palatal canal. This confirms what many of us see clinically, that extra palatal injection makes a real difference for these teeth with irreversible pulpitis. Let's talk about MTA, a true miracle in endodontics. Traditionally, MTA pulpotomies have followed a 2-step protocol. First session, placing MTA, covering it with a moist cotton plate, and sealing with a temporary restoration. Second session, verifying MTA setting after at least 24 hours, then completing the final restoration. However, recent research suggests a 1-step technique may be just as effective, simply waiting 45 minutes after MTA placement before proceeding with the final restoration. So, I'm curious, which protocol do you prefer in your practice? The traditional 2-step method or the streamlined 1-step? approach. Share your experience in the comments and stay tuned as we explore the evidence behind both techniques. Amal Singh Rana and his colleagues from India published a paper in Journal of Conservative Dentistry and Endodontics entitled Evaluation of one versus two-step techniques on the outcome of mineral trioxide aggregate pulpotomy in mature permanent teeth with symptomatic irreversible pulpitis. They found both one-step and two-step MTA pulpotomy techniques showed high success rates in treating symptomatic irreversible pulpitis in mature molars with no significant difference. The one-step method is an effective alternative to the two-step approach. This is great news for clinical efficiency. The study suggests we can achieve excellent results while saving patients an extra visit. Thank you so much for joining me in diving into these exciting new endodontic studies. If you found this video insightful, hit that like button, subscribe and ring the notification bell so you never miss an update. Your support fuels this channel and inspires more content, so drop a comment below with your thoughts, questions or suggestions for future topics. I read everyone. Until next time, keep innovating in your practice and I'll see you in the next video. Stay curious.